Hello, everyone. Welcome to our sixth Global Healthcare Travel Forum and Conference, which is being held in North Cyprus. We have recently completed the session one, and now we are proceeding with session two. Our first presenter is Dr. Kaya Suer.
Hello, everyone. I'm going to talk about the climate change and the infection. How did they become a couple? Climate change is causing milder winters, warmer summers, and fewer frost days. This change in climate makes it easier for many animals, mosquitoes, ticks, and the infectious disease they spread to expand into new geographic areas and infect more people. With increasing temperature, animals that carry ticks, such as rodents, deer, and raccoons, are expanding their habitats. The warming climate means that ticks emerge and start biting earlier in the season than ever before. National Center for Emerging and Zoonotic Infection has increased the support to states to improve the tick surveillance and reporting. Harmful algal blooms that grow in fresh and salt water can have big impacts on the economy and the environment. Toxins from HAPs can make people and animals sick through seafood or water. As the climate change, the risk also increases for health threats such as anaplasmosis, anthrax, antibiotic resistance infections, dengue fever, giardiasis, hantavirus. A lot of microorganisms make the more easily infection in the human body. And also the other disease, for example, Lyme disease and the rabies, maybe it's not seen in the northern Cyprus, salmonellosis or West Nile virus, especially 2016 West Nile virus started seen in the northern Cyprus. Mosquitoes and tick bites, mild winters, early springs, and warmer temperature are giving mosquitoes and ticks more time to reproduce, spread disease, and expand their habitats throughout the world. The geographic range where ticks spread Lyme disease, anaplasmosis, eliosis, and the spotted fever rickettsiosis have expanded. And experts predict that the tick-borne disease will continue to increase and perhaps worsen. Longer, warmer summers have also given mosquitoes more time to reproduce and spread diseases. In this graphic, you can see the depends on the change in the global temperature. Mosquitoes earlier start to prepare the eggs, and then larva, pupae, and then goes to human. Insect the human body, and then disease transmission could be seen. Depends on the high temperature in a long period. Contact with animals. Climate change has forced some animal species into new habitats as their natural habitat disappear, and it has expanded the habitats of other animals. This movement of animals into new areas increases opportunities for contact between the human and animals and the potential spread of the zoonotic diseases. Wildlife carrying the rabies virus are expanding to new geographic areas of the country, but as an island in northern Cyprus, we don't see any rabies cases. Arctic temperatures are rising more than twice as rapidly as the rest of the world. Warming temperatures in Alaska have led to increase in whale populations, which can spread the disease like Alaska pox to humans. As global temperature rise, deadly diseases that are treated in other countries like Ebola, Lassa, Rift Valley fever, and the monkeypox will increase along with the risk of them being imported into the world. In this slide, you see the climate change, direct and indirect pathway, and start to animal disease. In fungus, rising temperatures have allowed to certain disease-causing fungi to spread into new areas that previously were too cold for them to survive. Valley fever caused by a fungus that lives in the soil in hot and dry areas has already spread into Pacific Northwest. This fungus can cause severe infections and is often misdiagnosed and treated inappropriately. Valley fever, it's a coccidioidomycosis, a kind of fungus. As the difference between the environmental temperatures and the human body temperature narrows, new fungal diseases may emerge as fungi become more adapted to surviving in humans. Climate change also increases the risk for natural disaster and flooding, which can increase the risk for mold to grow in the people's home. Certain molds can cause deadly infection of the lung and the brain, for example, coccidioidomycosis. Climate change and infection in Turkey, there is a risk of increasing incidence of sandfly and mosquito-borne diseases, such as cutaneous visceral leishmaniasis and West Nile virus infection, which has local transmission currently. In addition, there is a risk of spreading of malaria, Zika virus, dengue virus infection, chikungunya, yellow fever disease, of which there has been no local transmission currently, but important cases are being reported. In Turkey, specific invasive Aedes species, which are the main vectors of such diseases, have been detected in certain regions. And also Aedes species, especially Aedes aegypti, first time is recognized in the 2022 in northern Cyprus. Zoonotic disease, such as Crimean Congo hemorrhagic fever, hantavirus, leptospirosis, Lyme disease, Q fever, that has local transmission, currently could spread to region where this disease had not been observed before. Disease control programs are carried out by the Zoonotic and the Vector-Borne Disease Department for the prevention and control of the zoonotic and vector-borne diseases. Climate change and the infection in northern Cyprus, we need more studies because, as you see, I said some of the infectious disease problem before. Most of them is not checked in the northern Cyprus. We know something about the West Nile, but we don't have any chikungunya or the dengue fever in northern Cyprus until today. That's why we have to make some of the screening in this country. Here is the references, and we have to wake up against the infections. Thank you.
Thank you very much, Dr. Kaya, for your valuable presentation. And our next presenter is Dr. Ülvan Ozat.
Hello, good morning, Dr. Bekir, and everyone who's watching the presentation. Can you hear me? Is my voice okay?
Yes, Hocam, everything is all right.
Thank you very much. First, I would like to thank Professor Dr. Kaya Suer for his valuable presentation, our very own professor who takes a pivot role in infectious diseases in Cyprus. Now I'm going to talk about communication barriers to health tourism. I work in the plastic surgery department in nearest university, and we perform health tourism on a daily basis. We encounter several communication barriers, and we keep thinking about them. So we wanted to turn this into a research, and we try to find solutions for everyday problems that we experience. The main language we use in health tourism is English now, but it's not only for us medics. Because of the Western colonization, English started to spread to other parts of the world since 16th, 17th centuries. And in early 20th century, English became the language of science and technology. Later in 20th century, because science and technology is better in UK and USA schools, universities, English became the medium of instruction in high schools. And in the last quarter of 20th century, World Wide Web developed, and this turned the world into a global village, according to McLuhan. And English was the main language of the World Wide Web, so it gained the status of international language. But unfortunately, not everyone can express themselves perfectly in English, and knowing English is not enough to explain yourself, explain your health concerns, and to communicate greatly with the medical team. We have interpersonal communication skills jumping in at that stage, and we struggle with communication barriers on daily basis. There are 6 important barriers. The first one is semantic barriers, language, psychological barriers, organizational barriers, cultural, physical, and psychological barriers. The first is language barriers. There are 3 important things that we experience. The first one is poor quality of message. This means the message is not precise and easy to understand. We sometimes explain things in detail, but we forgot to give a simple explanation, and it becomes very hard for the patient to understand what we try to say. It's same for doctors as well. Sometimes patients explain their problems in detail, but they don't mention precise key details that would make it easier for us to understand. The second point is lack of clarity or complexity of the way of providing information. So we are not clear. If I want to say, take this pill 2 times a day, morning and night, I should put it in the form as simple as possible. But if we make explanations complex, the exact message gets lost in the speech. And the third main problem is technical language. Sometimes we use medical jargon, sometimes we use technical words, and we think patients understand it, but actually they don't. The second barrier group that we experience is psychological barriers, and this has a very important role in interpersonal communication. Empathy has a key role in psychological barriers as well. Both doctors and medical staff needs to demonstrate empathy to the patients in order to achieve a good interpersonal communication. In psychological barriers, premature evaluation of the information by the receiver, even before it's transmitted, can cause a great problem. For example, if someone comes for a facelift operation, and there's a patient experiencing complications, sitting in the waiting room, suffering from pain, and the new patient sees this old patient, they get into the psychological state of not wanting the operation, getting afraid from the complications, and whatever you explain, they would set up a barrier in their psychology for the operation. The second important thing is inadequate attention from the receiver's end. So if you lose the attention of the patient, whatever you explain, whatever details you give, they wouldn't be listening to you. They wouldn't be paying attention, and the message will be lost. And the third group is passing information from multiple resources. So we have 3 doctors speaking at the same time, explaining different things. The patient, the receiver, will be unable to retain everything, and most of the information will be lost. The next communication barrier group is organizational barriers. This is usually due to bureaucracy and hospital staff. This is barriers caused due to structures, rules, and regulations that are present in the organization. And this mostly takes place due to superior and subordinate relationships where the free flow of communication is not possible. So if the main communication media in the hospital is emails, and you need to email your boss, you need to email your head for very little details, it would take very long to answer the patients, and you will have barriers in communication with the patients. The next group is cultural barriers. These barriers arise due to lack of similarities among different cultures across the world, and this is inevitable. This is very easy to think of, but we usually forget about this in daily practice. So a great example is a term that can be harmless in one language can be regarded as slang in another language. Or in terms of religions, we have various beliefs amongst different cultures. We have different customs, beliefs, religions, attitudes, socioeconomic differences, and even daily habits. So, for example, our hospital has very good hospital food. We have dietitian-controlled kitchen with professional chefs cooking the meals. But sometimes people from Britain come for health tourism, and they call us and they ask if we have cheese and bread toast because they can't eat the traditional food that we serve. So there's usually an extra meal that is more continental for such patients. So we need to take care of what patients eat, how they act in daily lives, what their values are, what their customs are, in order to prevent cultural barriers arising. The next group is physical barriers. These barriers can be caused due to certain factors like faulty equipment, noise, closed doors, cabinets, or like having dyslexia, having hearing disorders, nervous disorders, or any condition that would interfere with the speech or hearing. And also the style, the tempo, the tone of the speech is very important, as important as the language. If a doctor speaks very slowly, the patient can get bored and the attention can be lost. If a patient speaks with screaming tone, the patient might feel intimidated and might close himself or herself to the conversation. If a doctor speaks very fast, the patient might not be able to understand. So these should be taken care of during communication. I want to get back to language barriers because this is very important. I want to make one more point in terms of language barriers. When we're learning a language, we learn the grammar and the form, but language is more than this. There are speech acts, and the way you speak language also affects the communication. The way you speak the language also affects the message you give. And we need to use appropriate language in terms of quantity, quality, relevancy, and manner. So we need to give good quality information. We need to avoid uncertainties. We need to give good quality information. We need to speak of what we are certainly sure of. We need to speak about relevant stuff. We need to speak in a welcoming manner. And there's another concept called semantic overload. We need to try to avoid complex sentences, long sentences, the technical jargon. Even if we don't use technical jargon, we can explain something that sounds very basic to us, but patient wouldn't understand at all because they don't have the medical information that we have. And also, people from different cultures, people from different countries tend to speak in different ways. Us, Turkish people, we speak in circles. So we explain something, we give all the details about that thing, we speak about irrelevant things, and then we move into something else, and we speak about those as well. So we explain things in circles. On the other hand, for example, British people tend to speak point to point. So they give one information, and then the second point, and then the third point. They speak in a very structured way. European people, on the other hand, they give one point, they explain it, they move to the second point, they explain it. So they give explanations in order. So as a Turkish doctor, if I try to explain the operation timings and the operation details to a patient in the Turkish manner, in circles, maybe the patient wouldn't be able to understand anything or would get confused very much. So we need to take care of how we speak, how we explain things as well. Finally, we have some classical steps established in literature for health communication. And we tend to think it's the same for health tourism as well, but I want to demonstrate the differences of health tourism and classical steps in health communication. In classical health communication, the initial contact is with the clinic staff, but this is not usually true in terms of health tourism. The initial contact can be with the agency as well. The second activity is doctor meeting the patient with small talk and socialization. And the third point is consultation. So doctor puts a professional distance and makes a diagnosis or examines the patient. But in health tourism, it's usually the other way around. First, there's consultation, either online or face-to-face. But first, the doctor analyzes the patient, and then small talk socialization comes in. The fourth step is getting back to doctor's office after the treatment for results and feedback. This is true for both. And usually in the future treatment, there's nurses and other staff involved in classical health communication. But again, we have the agency getting involved in health tourism. And the final step is payment. But usually this goes way before in health tourism. So a keynote is we shouldn't expect to have a normal patient-doctor relationship process duration in health tourism. Sometimes the things get swapped around. And the second thing is in communication for health tourism, doctor is not the only message sender. We also have agencies involved. So the communication of agencies with the patients also affects the treatment process that we provide. That should be taken care of. So what can be the possible solutions to these problems? The first thing is awareness. We should be aware that we experience or we may experience these problems. Trainings could be provided, basic training could be provided to doctors and medical staff as well as agencies to avoid these barriers. And also information booklets about the cultures can be produced by hospitals or agencies to prepare doctors for what to expect in terms of culture from their patients. This is an example that one of my previous teachers wrote, Joseph Spitzer. He is a Jewish GP in the UK, and for British patients, for British medical school students, for us, for international medical students, he wrote a book about Jewish culture. So when we went to his practice, we knew what to expect from the patients. We knew how to act to the patients. So, for example, in Cyprus, we have Russian patients, we have British patients, we have European patients. We can prepare several cultural booklets and doctors can read it and know what to expect when they see the patients. Thank you very much for listening to me. I can take any.
Thank you very much. Thank you very much for your valuable contribution, Dr. Ilvan. Thank you for your presentation. So this is the end of session 2 for today, and we will be following by continuing on the session 3 at exactly 12 o'clock, considering the Cyprus local time. Thank you very much.
Catching a bus, never feeling a straight